Why does general, you're skeptical? First of all, okay, let me, like all good academics, let me retreat behind all the studies, and I mean all the studies ever done on this topic show that that's the case. That, in fact, when people switch from jobs that have health insurance to jobs that don't, an equivalent full dollar-for-dollar payment. And I'd be happy to provide you with all the citations. But let me ask you, this seems to be a slightly skeptical crowd. General Electric provides health insurance to its workers because it's benevolent, because it's paternalistic, because it really cares about its workers, or it provides health insurance to its workers because that's what it has to do in the marketplace of labor to attract good labor. Now, I suspect a skeptical audience is not going to buy the first explanation, but is going to buy the second explanation. That's what they need to pay. Now, suddenly, you get rid of health insurance as a bargaining chip. What's your next bargaining chip for a worker who you want to attract? It's called salary. You're going to move the money they spend in health insurance to the salary column, and workers are going to demand better salaries. Ask any economist. Go to the economics department at Case Western and ask them, is benefits, fringe benefits, part of total compensation? And they will say yes. And if I take away that fringe benefit, if that no longer has to be provided, what's going to have to happen to total compensation? It'll stay the same and it'll just raise. Why will employers still be interested in our plan? Because it's not the compensation today they're worried about. It's the fact that they can't control healthcare costs year to year. It's inflation they're worried about, because inflation in healthcare exceeds underlying inflation, and so it's eating up more and more of their budget. That's why they would like to offload it into our plan. Again, just ask yourself, why are they providing healthcare today, and what would they do if they didn't have to provide healthcare? And I assure you, raise salaries. The third thing that would happen under the system is that federal taxes would change. Right now, out of general revenue, $150 billion of the federal general revenues goes to healthcare, separate from Medicare and Medicaid. That goes away, so the federal taxes would change, and then as Medicare is phased out, the Medicare payroll tax will be phased out as well. So, in net, most people should be revenue neutral under our system. The value-added tax rate is flat. Congress could raise it or lower it. I don't think that's going to happen every year just because most Americans are not wild about paying taxes. But I think over time, we know that as societies get richer, they spend more on health care, we will see the rate go up little by little. Now, given that long explanation of your first question, what was your second question? Oh, a 90-year-old and rationing. Okay. There is no, in our system, we do not imagine a central rationing idea at all. And I actually don't think rationing is going to come to our system. So let me tell you the two ways I imagine decisions are going to be made. First, we have an Institute for Technology and Outcomes Assessment, and the very first thing we're going to find out is what is the value of a lot of these interventions that we're doing. I have a whole talk through many, many different healthcare interventions that add no value and we're paying a lot of money for it. I think with systematic evaluation, those interventions are going to soon disappear. Not overnight, but they're going to disappear because health plans aren't so stupid. They realize you don't get a lot of value for that, you don't get a lot of improvement in healthcare. Why are we paying $55,000 for that drug? Second, if people want last-ditch therapies, there's nothing standing in their way of buying insurance. And I think there will be some insurance products out there for people who want to buy that kind of coverage. I don't think they're going to be popular because I think most Americans say now, I'm not sure I want that. But, rather than someone saying yes or no, there will be an insurance product. You want that drug, that last hope drug for your cancer? There's nothing in the way of you buying an insurance product before for that medication. So I think that's how it happens. Finally, I think you're going to see, we have in pharmaceutical benefits now, tiered benefits. So you pay $5 for a prescription of a generic drug, $10 for a cheap brand name, and $25, $50, whatever it is for an expensive brand name. You'll see a lot more of that related to healthcare services. So where there are options, for example, like prostate cancer, you could get radiation or prostatectomy or watchful waiting, you will see different benefits associated, or different costs and co-payments associated with those different services. So that's how I imagine that would be handled.
Today at the City Club of Cleveland Forum, we have been listening to Dr. Ezekiel Emmanuel, Chair of the Department of Bioethics at the National Institutes of Health's Clinical Center. Thank you, Dr. Emmanuel, for your fascinating presentation. Thank you, ladies and gentlemen. This forum is now adjourned.